so while they're reading their questions, I'll go ahead and field this one. What is being done to educate pediatricians on the signs, symptoms of KD in order to prevent so many misdiagnoses, and I would also say missed diagnoses? Dr. Tremblay is going to talk to you about the very exciting work that she is leading in creating a diagnostic test. So I don't mean this in any kind of real pejorative way, but it's very difficult to create smarter doctors. What we need to do is give them better tools. And I think that coming up with a diagnostic test for Kawasaki disease is the only way that we're going to prevent misdiagnosis. So Dr. Tremblay and I tirelessly get on airplanes and fly around the country and lecture to groups of pediatricians. We've just come back from the American College of Rheumatology and the American Heart Association, but we also give grand rounds, which is a departmental function for pediatricians within different academic departments all over the United States. So we do spend a lot of time on an airplane going and trying to educate people, but it's kind of an uphill battle. I think that through our efforts here in San Diego, we live in a community where actually there is quite a bit of awareness about Kawasaki disease. I also want to say, though, that you can be part of the messaging system. So we have posters when you come to clinic. We've probably given you a poster and asked you to take it back to your pediatrician or to the urgent care where your child was seen and the diagnosis was missed. So you can be an important part of our educational mission. So thank you for that. And if you didn't get a poster the next time you get to come to clinic, be sure that Joan, our wonderful study nurse, gives you that poster and you take it to your pediatrician.
You have a large stack. You better get to work.
Well, why don't you go ahead and take one?
I'll take one. Okay. It says, will CT calcium score be recommended even if the echo is normal at age 5? So if there is no evidence for injury to the artery, no dilatation, no problem, no nothing, I would say not necessary. We don't really have any reason to think that normal is anything but normal, okay? So that's the majority of the patients, even if untreated. It's when the artery is dilated and normalizes that I'm a little bit worried. And so if the arteries weren't normal by echo, then a CT calcium score in young adulthood is reasonable. That's opinion. So there's really no data. We really don't have studies, but we have a lot of opinions, and actually pediatricians are very opinionated. But sometimes they don't see patients who are young adults. They see them until they're like 10 and they're done. So I see them when they come to the emergency room with a heart attack and they're 25 years old. So that's a problem. And Dr. Burns, fortunately, is on this committee that decides guidelines, and so she's going to straighten it out.
Some cardiologists are opinionated too.
So Lori, why don't you do one?
At what age can KD patients enroll in the adult KD study? So initially we were doing 18 and up, but we've revised our protocol to now lower the age down to 15 actually. So 15 is the answer. And thanks for asking that.
Okay, Dr. Burns, you got a big stack.
So some of the questions I'm going to defer until later because I think we're going to actually answer them for you. We're going to talk about KD seasonality. We're coming up on KD season now, and it will begin to build. Audrey says we're already in KD season. She's been busy. You know that Dr. Tremblay and I take turns being on call. That means that one of us is on call half of the year. So it's a busy season. In March particularly is the highest part of the year, and we're going to talk a little bit about why that might be. One of the questions here is, are children with Kawasaki disease predisposed to other diseases or other medical issues? And I really want to stress that we don't have the answer to that question, but that's why Dr. Daniels is doing the follow-up study. And the only way that we are going to learn the answer to that question is by having a large cohort of otherwise seemingly normal KD patients agree to be in this follow-up registry so that we can follow them long-term. And we absolutely do not have the answer to that question. There's a question here about a child who's in preschool and now getting lots of colds. That's normal. Has allergies. Lots of children have allergies. And a question about any other medications. So if your child is being followed by our group or by a pediatric cardiologist because of heart damage, your child may be on medications that would interact with some of these over-the-counter medicines, so you should just clear that up with your physician. For our children who are on low-dose aspirin, ibuprofen is one of the drugs that fights with aspirin, and so we like our kids to take Tylenol instead. But these are questions that you should ask the doctor who's following your child. So back to you.
This says, is it recommended for all KD kids to have an endothelial test every several years? I hope I read that correctly. So no, the endothelial cell tests that I was showing you are experimental, just so that we can learn more about this disease. We don't recommend that any of you need it, any kids with KD need it. Some very rarely will order endothelial cell tests for adult cardiac patients, extremely rarely, because it's mostly experimental to teach us more about the physiology of what's going on.
There are a number of questions here that have the basic theme about genetics and susceptibility. So as many of you know, we've asked you to participate in our DNA study. We have kits out there if you haven't already enrolled. Because we deal with a mixed ethnic population, the way we do our analyses, it's very, very important to have the DNA from both biologic parents. So a lot of times it's easy to get the child's DNA, you enroll in the study, you give us permission to get your child's sample, we then give you the mouthwash kit and you go home, and understandably we all have busy lives, it gets lost or misplaced and we don't get it back. So if you are one of those parents, we would urge you and love if you would pick up another DNA kit out there, because we really need the parents' DNA in order to be able to interpret the results for the child. Yes, we are part of a large genetics consortium that is worldwide and collaborating. We have a new initiative at Children's Hospital. Dr. Kingsmore has taken over a new genomics genetics center, and we have done whole genome sequencing on an African-American family with 2 affected children. If you have a child who had Kawasaki disease, it is possible for a sibling, perhaps as yet unborn, but a future sibling, to also get Kawasaki disease. I certainly wouldn't say that's not a reason to not have more children. I would just say that you are all KD experts after having been through this once. And you will certainly call Dr. Tremblay or call me immediately when your child, another child in the family develops rash, fever, red eyes, and red lips. And you will not hesitate to call us. And of course, you all know how to reach us, or Joan Pancari, our wonderful study nurse. So please don't hesitate to contact us if you have a question about another child in the family who might be developing Kawasaki disease. Yes, it can happen. Yes, this is a genetic disease. It is complex genetics, and so there's no way really to predict at this time whether or not another sibling is susceptible to getting the disease, but we hope to get there within the next several years.
This question says, my son had a 4 to 5 millimeter aneurysm of the proximal left circumflex artery with a high Z-score, so high for the size of the individual. The aneurysm resolved by 6 months. Will he be in the dilated resolved aneurysm category or the aneurysm category? So that's a great question. And so the answer to this is kind of our own opinion here, because the guidelines aren't very clear. But the way we categorized people for our study is that, yes, that would fall into the regressed aneurysm category, especially when it resolved at a young age, within 6 months. That's, we think, more consistent with the resolved aneurysm category. If someone is older in their 20s and has always had aneurysms, and then the aneurysms you don't see anymore, much later, that's not necessarily a good thing. That could be because it's filling in with clot, for example, but that we wouldn't expect to happen at this young of a time point.
A question here about our collaboration with both Children's Hospital of Orange County and Kaiser Hospital. Yes, we have contacts at both of those institutions. Dr. Tremblay is actually doing a study about infants less than 6 months of age who can be very severely affected with the group at Children's Hospital of Orange County. So there is collaboration and communication between these centers. Kaiser also sends over to us the more complicated Kawasaki disease patients for a higher level of care. So we certainly do collaborate and are always available for consultation with anybody anywhere in the world if we can be helpful in the management of KD cases. A question about eczema and the relationship to Kawasaki disease. We do think that those two conditions are genetically linked. So there's something about the way the immune system responds that a very high percentage of our KD children do suffer from eczema as well, which is an itchy chronic skin condition. So it's not a coincidence, it's probably real. And we do work with Dr. Winnis Tom in pediatric dermatology. She's very interested in the relationship between Kawasaki disease and both eczema and psoriasis. And so if you have particular questions or your child is having a problem with either of those conditions, Dr. Tom would be the person that I would refer you to at Rady Children's Hospital.
So my next question is, are chest pains in adult Kawasaki patients common? What do they mean? So I'm going to teach you what we teach medical students. There are many reasons for chest pain in all of us. I mean, some of you have had chest pain. Blocked arteries will cause chest discomfort, not necessarily even a pain, but a discomfort with exertion, and it's relieved by rest. Okay, so if you have spaghetti dinner and you have chest pain, it's probably not your heart. There really is a long list of why people have chest pain. Blocked arteries cause exertion-related chest discomfort relieved by rest. So it's no more common, perhaps, in Kawasaki patients than in anybody in this audience. So it's, what's the nature of the chest pain? And sometimes you need a doctor to figure it out. And the next question is adult KD, blackouts during cardiovascular activity, migraines, gastro problems, inflammatory joint disease, soreness in the mouth, rashes on the body. So these are all just problems that one might have in life. Once the acute illness is over, these kinds of problems aren't really likely to be related to Kawasaki disease. And Dr. Burns can comment, but I don't think those symptoms are from something else.
So I'll just say that in the adult follow-up study, we do have a number of individuals who have odd inflammatory conditions. Part of the ascertainment bias or the problem with people contacting us from around the country or around the planet who have had Kawasaki disease in childhood and now are experiencing some kind of bad problem, health problem, is that there's a bias in that these people are more likely to seek us out. So it's very hard to tease out whether the Kawasaki disease and their particular genetic background is responsible for the other problems that they're having, or it's true and unrelated. And that's why I really urge all of you, and for the people looking at this on YouTube, the people that we followed since their initial diagnosis, those are the people who are really going to inform us about what the long-term complications of Kawasaki disease may or may not be. And we really need people in this cohort of patients, that's our Kawasaki family here in San Diego, that we followed from the time of diagnosis. We need to keep track of you and follow your children all the way up into adulthood in order to really be able to answer those questions. So we really urge you to stay in touch with us. And we're enrolling the kids at age 15, and there's a consent form for participating in the adult study. But those are the patients, the individuals who are going to be able to answer that question.
Is there a national database tracking all the KD patients? Unfortunately not. KD is no longer a reportable disease, even in the county we were one of the last counties that actually had it. And because of funding, it's no longer a reportable disease. But we are working very hard in trying to get some good numbers, but unfortunately there's no database tracking that. We do have, we're trying to work with a database registry through Sanford Health for rare diseases to be able to get more information.
So a question about El Nino. We've all been hearing about how we're going to have the killer El Nino this year, right? And everybody's getting their gutters and their roofs fixed. And the question is, will it have an effect on KD season? And we think the answer is yes. We think that the El Nino weather patterns actually bring in a lot more circulation from Asia into Southern California. And so we are bracing not only by repairing the roofs of our homes, but by kind of planning our schedules that we think this is going to be a really big KD year. So we do think it will have an effect.
How do you define transient coronary dilation? My son had slight dilation one day after IVIG. He took Remicade and it disappeared. So we're really trying very hard, and Dr. Burns is trying to lead this effort with the new guidelines of getting away from kind of putting kids in boxes and labeling them, and really being able to use Z-score because it's a continuous number that we can look at over time. What I would say is that a child that I see that has a little bit of swelling and then it goes away on a repeat echo, especially if it's within a few days, I would, in my mind, categorize that kid as pretty low risk and as a transiently dilated child.
There's a question about dilation of the proximal aorta. So the aorta is the major blood vessel that leaves the heart and carries the blood to all the other branches. And the coronary arteries, as you saw in the angiograms from Dr. Gordon, are connected to the proximal part, the first part of the aorta. And so it's not a great leap of faith to understand that inflammation in the wall of those arteries could also sort of spill over into the wall of the beginning of the aorta. And so 15% of our patients have dilation of that part of the vascular structure. And that seems to go away in most patients over time. It may take a couple of years to resolve. One of the questions that we have is whether there's been any scarring in that part of the vasculature that over decades, not immediately, but over decades, might increase the work of the heart, because where there's been inflammation, there can often be stiffness or some scarring later on. And that's something that Dr. Daniels is studying in our young adults, whether there's some stiffness to the aorta that over many, many years would put an extra strain on the heart as the pumping against that increased resistance. So right now we don't know of any long-term effects of that, but it is something that's being studied.
So there's a question about how long it usually takes to diagnose KD. This family had a child that was diagnosed after a week. Like I mentioned, it's about 3 visits to the physician on average for families to be diagnosed. And so it's not unusual to have multiple visits to providers before then. And so this story about a week is not unusual, unfortunately. And we see kids as early as the first day or 2 of fever that have, every sign of KD that we know we can diagnose. And some kids take a lot longer because they don't have all the signs. Along those lines, there's a question about specific blood work, and I just want to make the point that it's that blood work is actually really helpful for us, although we don't yet have a particular diagnostic test for KD. There are patterns of common blood tests that are done that we're using in that iPhone app that I showed you that help us determine. And there's actually, for the American Heart Association in the 2004 guidelines, there's a specific algorithm that's out there that helps physicians determine how likely, well, it actually helps physicians determine whether or not somebody should be treated and whether or not an echo should be done, and that involves blood work very closely.
Question about genetic testing. Is there any way to do genetic testing to identify whether children are susceptible? Right now there is not. Our focus right now with the genetic work is to try to come up with an understanding of the special genetic predisposition that children may have to developing the coronary artery damage. So we know that before we treated people at all, or when we had, unfortunately I'm old enough that I remember those days when we had no treatment for this disease, only 1 in 4 children without treatment will develop the coronary artery damage. So it's a special genetic subset. And our genetic studies are really focusing on who are those children, what is that special genetic subset, so that we could target those children right away by doing, let's say, a very rapid genetic test when they come in through the emergency room, and then they would be eligible or candidates for the advanced treatments that Dr. Tremblay is studying. So that's our direct goal for the genetic testing, but it's not available yet.
So there was a question about vaccines and specifically flu shot after IVIG. So in terms of vaccines in general, we say that to get a live viral vaccine, so that includes the measles, mumps, rubella, and the varicella, it's 11 months after receiving IVIG that those can be given. So in some children, especially if you're just around a year or 15 months or just about to turn 4, that'll affect your vaccine schedule. Otherwise, the vaccine schedule is really not altered. There was a question particularly about flu shot. I will tell you, as an infectious disease physician, we're due for a big flu season. We're already seeing it. Please, please get your flu shots. And your Kawasaki patients, or Kawasaki patients, your children should also get their flu shots. We recommend getting the injectable if you've had IVIG in the last year, only because there's no data as to the live virus through the nose, the live viral vaccine, what the uptake is in children that have gotten IVIG. So, but everyone should get their flu shot, because I don't want to take care of your kid as a flu issue in the hospital when I'm on service between Christmas and New Year's. Changes of the recurrence of KD. So this happens because of, so recurrence is really tied to the genetic susceptibility, and there seems to be some ethnic divisions here. So the recurrence rate in Japan, it seems to be about 10%. In our Asian population, we tend to be more Filipino, Korean, it's about 5%. If you're Hispanic or white, you have less than a 1% chance of recurrence. We, for some reason, see recurrence around the 1-year anniversary. We usually don't see it past about 5 years. And someone asked about how many times you can have KD. We have seen children that have had it twice. Have we had anybody be more than that?
No, there are some kindreds in Japan where some children have had it 3 times. And I suspect that that has something to do with their individual immune system and a failure to mount immunologic memory, which should protect you from future exposures. We do think, and whether it turns out to be the wind and the particles or whatever, I think we can be fairly confident that whatever it is that triggers this is widespread in the environment. So I don't want any of you leaving here today thinking, oh, if I just hadn't let my child go out on that windy day, or I just had to clean my carpets, or whatever. The epidemiologic data suggests that the trigger for KD is widespread in the environment. That's why most of the children who are going to get it before the age of 5, because they're born with a genetic predisposition, and it's something fairly common in the environment that they're going to come in contact with. So it's nothing that you did or didn't do. There's nothing that you could have done to protect your child from getting this. It was going to happen. And that's our current understanding of how this disease operates.
questions about supplementation and giving your children vitamins or calcium or something of that nature, and there's no data to support that that helps or that that hurts in any way, so there's nothing to say that we should or shouldn't do that for our children with KD. A question also about negative consequences from IVIG resistance. So, and in this particular question, this child had normal echoes. So to fail IVIG increases your risk of coronary artery aneurysms. So if you have no treatment with Kawasaki disease, you have a 25% chance of having an aneurysm. If you get treated and you respond, your aneurysm rate is about 3 to 5%. However, if you're IVIG resistant, you're somewhere in the middle. It's about 15%. If your child had IVIG resistance and got Remicade or a second dose of IVIG and had no heart issues at that time, then there's no consequence from that. So it's really tied to the heart disease. And then there was a question about siblings. I don't know if you guys talked at all about twins at all briefly, but just to mention, just to bring this up, so there was a question about kids being sick at the same time and who needs to be evaluated and for what. So I just wanted to make the point that we have seen, and we have a paper out about twins being affected with Kawasaki disease. So identical twins share 100% of their genetics, and if they live in the same house, they have the same environmental exposure. And so in those children where we have an identical twin, where we know that one kid has KD, we actually do blood work on the other child, and if there's inflammation, we'll do an echo on that kid, because we have had twins where they're both getting KD at the same time. In terms of siblings, they don't all have to get KD at the same time. We've had families where one gets Kawasaki disease and then a few years later another child gets Kawasaki disease. In terms of the workup that should be done, what we tell families is that this is where the blood work really comes and helps. So if you're suspicious about your child having KD, and we get calls all the time about this from community pediatricians, where either there's been another child in the family that had KD at some point and mom is now worried. I got this call 2 days ago. Mom is now worried about this other child having KD because he's got fever and rash. The blood work really helps. And they contacted us and we were able to see that there wasn't a lot of inflammation and the KD was less likely. So the physicians in the community love us because they know that we're available to answer their questions, and the ERs call us from all over the place, and we're here to really be able to help guide families to know, and guide physicians to know when further workup is necessary. And I think with that, we will thank everybody for coming, and we'll be around to answer any more questions you may have. So thank you very much, and spread the word about Kawasaki disease and what it is. Thank you.